just finished doing this week, so if you don't mind, I will kind of go through like the imaging without describing where the indicator is and all that, because you all know by now. And we probably won't talk a ton about his actual valve anatomy yet, because I'll just get through the midterm protocol. We'll finish the videos.
You do the midterm protocol?
Yeah. So see what you can notice the differences before I even talk about it, and then once we finish the video, since you guys can just study that separately, then we'll look at some fun stuff. Okay? So I'll start out in the middle of your chest right here. You said the aorta's gonna be huge? Hey.
Yep.
Yeah, she beat. Alright, so a full picture sternal starts out with the increased depth. You first take a moving picture of that. Really pretty pictures, you're photogenic. I don't know if they tell you that at places. They're like really easy pictures. So then we'll just go for a normal depth. So we'll take a moving picture. I like to take two just because from here we're actually going to freeze and measure. So we'll go back to end diastole, yeah. And now we're gonna do our cycles. So we're gonna get into calc package. We're gonna go to dimensions. We're already there. We'll start out just at the IVS. So interventricular septum and diastole, like this. Track wall is sticky. A nice place to know where to measure the posterior wall, if you can see a papillary muscle insertion, you can see where the papillary muscle starts, and then the, yeah, so it's like the muscle comes off of there, so you know that's where the wall is. So I can be really confident that that's where my measurement is. Cool. So then I'm gonna print that. And then I'm gonna scroll forward, so same cycle for end systole. You're gonna measure the same thing. So calc package, interventricular septum, internal dimension, posterior wall. Now what else do we measure here? Remember? Left atrium. We measure the left atrium and end systole because it's at its largest dimension. Okay, so I'll print that. And then I can unfreeze. We finished our cycles, so we do both measurements in end systole and diastole. And then what we're gonna do is our M mode. Go through the aortic valve. Just take a frozen picture of that. Move it through to the mitral valve.
Is that your Annie, right?
What's up?
We're seeing the Annie, right?
No, not necessarily, even though it does look like the same shape of the ENA wave. It's essentially the same because it's the motion of the mitral valve opening first and then opening again. So, yeah, and then the blood flow direction reflects the same kind of motion where there's two openings, or kind of two, what am I trying to say? Two moments of blood flow. So you see, I just kind of scrolled over to the papillary muscle level. And then we're done with M mode. So now I know I had you guys, I'm going to color the interventricular septum first. And then I am going to zoom in on the aortic valve and the aorta so that I can measure it better. Moving picture of this color. You don't have to change the scale because, again, if you were to see interventricular septal defect, it would be high velocity blood flow, so the scale is appropriate. So now I'm going to take my zoom. I'm going to go over to the aortic valve. Come on in. So pretty. Okay, so I'm going to take a moving picture first, and then I will freeze it. And then I'm going to go into mid-systole to make sure that valve is as open as possible. And then I'm going to go into my calc package and go LVOT diameter. Take a frozen picture. And then I can also do color while zoomed. I know I didn't put this on your actual protocol, but we're going to do it because we really do it for every peristernal. So moving picture of color zoomed. And now I'm going to take off zoom. I'm going to just color that aortic valve with a standard depth. And then I'm going to move the color box over to the mitral valve. Make sure that I'm covering the whole valve, but it's still quite narrow so that your frame rate can see it. take a moving picture of that. Now that is everything for your standard personal. I'm going to start going into the RVIT view. So I'm going to tip
You
my...
you wouldn't measure the aortic root at all?
I could. Sorry, I didn't put that. But what I would do to measure the aortic root, so I'm seeing it really quite well from here. When we actually look at aortic dimensions, what we can do is jump up a rib space and see that ascending aorta dimension. Sometimes it's kind of hard because of the ribs, but I'm going to move my focus up. You can see the ascending aorta until the arch sometimes. And you can kind of fill in some missing information. I don't know that it's going to be the best on his windows. Let me get my picture. See if I can follow it. There we go. See how I brought in the more of that actual aorta? I have to make sure that I can trust that measurement because it's kind of coming in and out. But I'll take a picture of that, show it. But yeah, let's measure the root. I like the root from the standard view better. I can trust that it's on axis and measurable. So I had to zoom back in. Moving picture.
Will you ever do like the LDOT and the root in the same image?
Not the same image because we would actually measure the root at end diastole.
Oh.
So.
Oh yeah. Okay.
Mhm.
Why end diastole?
That's its largest dimension.
Oh yeah. Okay. Because there's fluid that's or blood that's sitting there.
Mm-hmm.
What's on its
That just kind of chilling and filling.
Mm-hmm. I'm gonna try to. Okay. Those at a really good spot. Beautiful. Okay. Going in with my count package. Aortic root diameter. Go outer edge to outer edge, or to inner edge.
Outer edge to inner edge.
Outer edge to inner edge.
And
Yeah.
is that one dependent on the facility?
Very much so, unfortunately. It's technically ASC guidelines, but some places follow old ASC guidelines or amended ASC guidelines, so it's a little, yeah, something worth checking on. Here we go. All right, so now I'm gonna unzoom. We'll continue on through the midterm protocol. I moved down a rib space for this picture. I went to the RVIT view, so we're looking at the tricuspid valve now. I just wanted to let you guys know because this is the picture that I was getting from my higher window. I think I was just getting into a rib, so I moved down.
This is tail up.
Yep, this is tail up, probe toward the hips. So moving picture first in 2D, color. I could have narrowed my sector width, honestly, but I didn't do that. You guys know to optimize. So moving picture, and then I'm gonna go continuous wave, looking for TR. I'm gonna lift my baseline up. And we have a really incomplete envelope, like just a minimal width, very physiologic, very normal. So I'll just put a caliper where I see the max, but you guys don't have to do that. For your TR pictures, you're just showing it essentially. It's the inflow velocities that we'll be tracing VTIs of. But I'll just show you, if you do see a little envelope, you can put a caliper at the peak where you can see it. I wouldn't put it here because that's imaginative. I don't actually know it's there. I can assume that that's the direction that it's going, but I can't actually see it. Oh, that's even prettier.
Nice.
What happened? I know.
Wow.
Really pretty. I'll take it again. Okay, now I'm going to pass back through regular old standard parasternal, and then I'm going to go for that palm on it. The RVOT view. I'd say on most patients, most people, it's really quite hard. I will say you guys have really nice views. And especially on people who have had surgery before, it is so hard to see. I think I'm getting it. Can I have you tilt toward me just a little bit more? Yeah, like a steep face. Alright, I'm gonna let color try to be my guide because I think this is it right here. Yes. See that blue in systole? Flash, that's where we're at. So I'm gonna see if I can get it any better, but I know I am there. Can you try taking a little breath in and then blow your air out? I'll tell you when to hold. So hold right about there. Nice. Okay, breathe. See that? Breathe normally. I'm gonna bring it back up on the screen. See that little bright? That's gonna be valve replacement. Okay, that's what I was going for because I knew that there was something in there. But let's go back. How do I get out? All right. So now I'll use color. Okay, do the same thing. Little breath in, then out. Okay, and hold it out right there for just a second. Okay, breathe normally. Okay, now I'm going to do continuous wave. Okay, a little breath in. Load it up. Hold it out there for just a little. Okay, breathe. See, when I tried again, I got a higher velocity. So at first I was getting like a fainter signal and like a lower velocity. I just wanted to adjust my scale because I could hear, once you get a trained ear, you can hear a higher velocity. You can hear the sound difference between each valve. I heard that there was something hiding back there, and I think I was just a little bit off axis, and so when I changed my picture a little bit, I brought in that higher velocity. So here, I'm gonna take my first VTI measurement. So I'll go in my calc package. This is the pulmonic valve, and then this is just gonna be your PV VTI. So exactly how it sounds. Start up at the baseline, click, and then trace all the way down. Now this is gonna get your velocity max. It's gonna get both your max and mean pressure gradient, so it's gonna do all the heavy lifting of the equations that we learned about for you. You measure all the way up to that valve click, because that click right there, click, 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 that's showing where the, measure between clicks, exactly. That's showing where the valve closes. So remember how we were saying with valve prosthesis, valve opening and closing clicks are more prominent? That is true, and it's helpful. Okay, so then I'll print that, and then I'm going to do my, that's a prettier picture. That just keeps happening to me. Every time I come out of Doppler, my picture is prettier. I'm gonna use my pulse wave. Now with valve prosthesis, it's kind of hard to estimate where that valve begins. I believe that this is where the valve is. And then just above that is gonna be our RVOT, so our right ventricular outflow tract. I'm gonna place it there, and I was correct. It's just above the valve, yeah. All right. And now we're gonna trace this as well. Because what this gives us is information for the continuity equation. So we're getting what the blood flow velocity is right before the valve, and then right the peak at the valve. Yeah, exactly. So that's why we trace both. So back into pulmonic valve, now RVOT. Hello.
Was that automatically
VTI.
do your stroke?
Very
volume?
much. Yep.
Yeah.
That's the information you give the machine to do that for you. So nice. We don't get paid enough to do that, man.
It's a lot of math.
It's a lot of math.
Unnecessary. It's actually unnecessary math because
Yeah.
we're
It's
in the 21st century.
I know, for real. All right, so that's all for that. Now I'm gonna just go back to my standard plaques, and then I'm gonna rotate into, oh my gosh, hello. I'm gonna rotate into short axis. Now it's gonna look different because we're not gonna really be able to see those leaflets as well with the mechanism. Oh, actually we can see them so well. I lied. Maybe you can lean back a little bit like you were before. Perfect. The photogenicity here is really working in our favor. You're a really good example for their first person to see that's like a real patient, because you actually do have good enough pictures for them to see what's going on. A lot of people who have valve replacements, there's just a lot of like shadowing or brightness that obscures it. There we go. Okay. So the first picture I'm going to take is when I want to make sure I can see kind of the aortic valve the best. This is the landmark for a really good short axis at the base. I'm I'm just moving back and forth between this higher and lower window to get my best view. Okay, little breath in, and then blow it out. Hold it right there for a second. Breathe. Now remember, with the RVOT, it was hard in parasternal long axis. I didn't actually take my picture. How annoying. It's because I had my pulse wave halfway selected. That's crazy. Do another breath out. And then hold it right there for just a little bit for me. Okay, breathe. So I was telling you guys this. Some of you were struggling with your RVOT view from parasternal long, and then you would also notice there's that same shadowing for your RVOT. You can expect when you're in the same window, even when you twist your, when you rotate your indicator, you're gonna have the same problems as you did in the other view. So it's just gonna be kind of hard in hiding, but that is okay. So now starting out here, the first thing we're gonna do is color the tricuspid valve. So I'll narrow my sector width, kind of focus in on over here. You don't have to take another two-dimensional picture because you just did, but we're gonna focus color there. Then we're gonna do continuous wave Doppler. I'm gonna make my scale a little bit higher because I lowered it to see my pulmonic valve velocity better. I'm just gonna show this. And then we're gonna kind of work our way across the screen from left to right this time. I'm gonna round out my aorta and try to see all of the leads. Did I have you guys zoom? I don't think I did.
I think you said we got.
Oh, this
Bonus
is what I
points.
yeah, this is what I
Bonus
said.
points.
Okay, it wasn't zooming in parasternal long axis, it was zooming in parasternal short axis that I said we don't do, but I'm gonna do it here because we have a cool valve replacement to look at. So see all three of the leaflets. So bop, bop, bop. And then I'm going to do color as well, which again, you don't have to do this zoomed. You can just kind of work your way across in a normal depth. Nice. And now I'm going to really try to, I might have to change what window we're in. Oh my goodness. Pressing every button. I might have to move around a little bit to get that RVOT optimal, just like I had to do in parasternal long axis, but then we'll be done with this. Okay, now I'll have you take a little breath in and blow it out. And then hold for a couple seconds. There we go. Breathe. Nice. So see, it's right there. See those kind of like reverby brightness? That's just from valve replacement. So color shows us that we are where we think we are. Take a little breath in again. And then exhale. Hold for just a couple seconds. Okay, keep holding if you can. Okay, breathe. Good job. Now, do you guys believe that that's the true velocity?
There it is.
It's coming in and out. Yep. Okay, little breath in. Blow it up. Hold there. Good job. Isn't that really cool to see what a big difference your understanding of what's a true picture or not, or just your willingness to try? Because if you don't try, you won't know if you have your best picture. So just even the breath holds. So again, we're gonna do a second tracing of the PB/VTI. We want them to be comparative. We'll take our maximum. Well, there's a machine setting that has your calculations based off of the one that is the highest. That's already built into it. So if you take 2, it will take the highest one. Now, there are some times where we need to change that to be just take an average of all of them when you're in like an arrhythmia. But most often, when you take 2 measurements, it's going to take the highest one. Okay, I'm going to do the same pulse wave. Okay, little breath in. Blow it out. Hold it. Good job. You can breathe. So this Philips machine has this RVOT VTI hiding under CO RVOT. You can just follow the word RVOT. It's not the diameter. It's going to be under this drop down menu. Oh no, not diameter. Just crap. It's going to be. No, stop. Break. Alright, I erased it. I'm going to assume you guys know you have to trace everything twice. So I'll show you that. And then we're going to move on to the mitral valve level because we've seen everything. Oh, lies. We have to look at the interventricular septum. Interatrial septum, sorry. That's exactly what I meant. Alright, there we go. Now, again, I really like color compare. If we don't have color compare, that's totally fine. You can just take two separate pictures, but turn your scale down to the 30s. Take a moving picture, and then return your scale to normal, and you can take color compare off. So now, mitral valve picture, it's just a two-dimensional picture first. Then flip. The gains a little bit. And then you're done with that. And you'll move on to the papillary muscle level. I'm kind of already starting to move down on the chest for this since you're going scanning lower and deeper into the heart. 2D, and then your color is going to go over the interventricular septum here. And you leave the scale the same. Right, and then just a 2D picture at the apex. So real low on the chest. Alright, that's all for peristernals. So now you can lie on your back, and I will take some pictures kind of at their belly level. You can just rest your arms wherever comfortable. I usually tell people for this part, you can just kind of put your feet up on the bed and bend your knees. Yeah, so you can get comfy. This. And I'll be alright at the spot in your belly where your ribs are.
Ooh.
It's gonna be real good. Okay, take a breath in this time, and then hold right there. Breathe. So just a moving picture of all four chambers first, which is nice without even a breath in. Okay, again, little breath in. Hold right there. Okay, breathe. And then we're gonna zoom in on the interatrial septum again. I'm gonna bring in my good friend color compare. Bring down my scale. And moving picture. Now I twist my indicator and look in that IVC. Where am I focusing? Oh my goodness, why should it go all the way around? Okay, so what I like to look for, I like this vessel to be all the way across the screen. That takes a twist of the indicator because right here I can start to see the IVC, but it doesn't open all the way up. If I twist my indicator, I'm twisting it left, honestly left, right, until you really open it up. It's not one thing or another. There's not one size fits all for this. But, and I also like to see mention of this hepatic vein, so it's the best. It's looking good. good. We can already see good respiratory response. So I'm gonna take a moving picture, and then I will set my M mode in there. And mode gains are always crazy. Okay, can you take a sniff in through your nose like this? Okay, nice. And then one more time. Awesome. Good job. Okay, so that is all for your midterm protocol. I'll show you something else kind of cool because we've got a really good subcostal picture. So when you have your IVC view, if you center out your picture, you can see that this is actually really close to the same as, you can start to see your tricuspid valve. It should be the same as like a short axis parasternal view that you're getting, because this is your interatrial septum. This is, now you're a lot farther away, right? You're scanning through liver, so your picture's not going to be as good quality from here, because you're a lot deeper. But then there's your aortic valve, so tricuspid, aortic, pulmonic valve over there. And now if it lines up, this is how we say we can do a whole study from subcostal. If it lines up, we could even do color on the pulmonic valve. Oh, so dark. See that we're actually there, and then we can put Doppler there too, since we're pretty much straight up and down. Same thing. So if you can't get your parasternal Doppler, try it from subcostal. And then if you scan down, then that's mitral. So it's the same movement of your beam scanning down like that. I'm just gonna zoom. It's so bright. Mitral. My indicator is pointed just where it is for short axis. So exactly same place. So that's, yeah, that looks just like your mitral valve level, but on its side. And then there's your really beautiful LV function shot. Okay, now here's another thing. I'm going to have you turn back up on your side now that we're done with the midterm protocol. I'm just going to take a look at apicals too, so to show you guys